I'm Alvaro Alencar. I'm an assistant professor at University of Miami Sylvester Comprehensive Cancer Center. I'm a hematologist, member of the lymphoma program at the university. So I was asked to review the hematology malignancy abstracts from ASCO 2017. And ASCO had abstracts that involve all the most important hematologic malignancies, or the ones that we see most frequently in the clinic, frequently in the clinic. So we picked 11 abstracts that represent each of these malignancies or these specific subtypes of disease with results that have some impact already today in our direct clinic practice. So there was one study that evaluates a new drug for treatment of primary myelofibrosis. The study has some good endpoints that are met, some endpoints unfortunately are not met, and it's unclear whether the drug will move forward in a potential approval. It's an interesting drug. It's called momelotinib, which is a JAK inhibitor in the treatment of myelofibrosis. It's compared to ruxolitinib. And the drug is known to have some better features that might be superior, but it didn't pan out on the study. We have a couple of very interesting studies in acute myelogenous leukemia with a drug called idazidenib that was eventually approved by the FDA last month for treatment of relapsed refractory AML in patients with one specific mutation called IDH2. I also reviewed some abstracts for treatment of lymphoma, mainly non-Hodgkin's lymphoma. One fascinating result on the treatment of follicular lymphoma, high-risk disease, that we know that the role of transplant is important, but we unfortunately don't have strong data to back us up in the use of transplant in relapse in this specific group of follicular lymphoma that has higher risk disease. So the study demonstrates that it's mostly comparison data, but that there seems to be a clear role of transplant in the management of these patients. Also, one very important question that we typically have in clinic in regards to the use of radiation in patients with large B-cell lymphoma that have bulky disease. It has been our practice to typically radiate these lesions at completion of therapy, but we have stronger and stronger evidence that we can bypass radiation in patients that have a PET-negative disease at completion of induction. And this study gives us a little more substract to really avoid radiation in this important group of patients. Also review some studies in multiple myeloma. Multiple myeloma is a field in very fast progression, and combinations are getting more and more complex. And these studies demonstrate the feasibility of some of these agents. The combinations are getting more and more complex. And one particular drug called daratumumab, which is an probably the most important drug that was approved for multiple myeloma in the last few years, and seems to be a drug that can be like rituximab for lymphoma. It can be added to the regimens and improve dramatically the response. So this was a phase 1 study that really demonstrates that the addition of this drug is feasible in the addition to an already very, very potent combination treatment. And one important study another important study on transplant, and that's the evaluation of allogeneic transplant in patients with HIV positive disease. So that's patients with hematologic malignancy that also have HIV, that are being treated with antiretroviral therapy, and there is always a concern whether these patients could undergo allogeneic stem cell transplant. So this study is a small study demonstrating that transplants are feasible in this population and safe, with no warning sign of increased rate of infections. I think in conclusion, the studies that we reviewed demonstrate the constant improvement that we are having in hematologic malignancies and the fast pace that it's happening. We have a drug approved in treatment of AML, something that hasn't happened in so long, and an extremely potent drug that it seems to be following what we typically see in AML. There's so many different mutations, and now we're individually addressing one mutation at a time with very potent drugs that are changing the paradigm of this disease. We're seeing progressive improvement in the treatment of myeloma, extremely effective regimens that are giving extremely high rates of response. And in addition, progressive improvement in the management of lymphoma, maintaining disease control and minimizing toxicity. So This just represents how fast and how important these changes are for our management on hematologic malignancies.